All right, hi everyone. So welcome to a review on adrenal disease. My name is Paul Bryan. I'm a second-year family medicine resident. If we haven't met before, feel free to pass along any questions that come from this review. Probably the easiest way to get a hold of me is on email at pmbryan, B-R-Y-A-N, at ucalgary.ca, and I'll be happy to try and answer your questions, whether it be preparing for exam, in course 4, preparing for clerkship, whatever the reason is that you're watching this, I'll try and answer your questions or get you to someone who can. Okay, so let's just jump right into things. So with the adrenals, so in general, what this is physiologically is the hypothalamus pituitary adrenal axis, which is shortened into the HPA axis. The HPA axis is a fundamentally important controlling mechanism and pathway within the body, and we'll get into that in a little bit here. So just as with other sort of pathways within the pituitary axis, similarly, we have hypothalamus signaling down to the pituitary gland with the corticotropin releasing hormone, or CRH here. So just to remind you again that in the signaling from the hypothalamus to the pituitary, you have two general categories. You have the anterior pituitary and the posterior pituitary. So the posterior pituitary has just the two hormones, oxytocin and ADH, and there's actually a direct neural link through the pituitary stalk between the hypothalamus and the pituitary. So actually through those neuronal axons, you get signaling. Now the anterior pituitary, which is where we have the CRH signaling happening, actually there's just a short jump through blood vessels, through venous blood vessels from the hypothalamus to the pituitary. So just like those other anterior pituitary hormones, the HPA axis utilizes that venous sort of direct transfer of hormones produced in the hypothalamus to signal the pituitary. So once we have signal in the pituitary, that gets released into the bloodstream and acts on the target organ, which is the adrenal gland here. So the adrenal gland is a really interesting gland just in terms of its sophistication of how many hormones it releases and the roles that those hormones play. So I like to think about the adrenal gland as sort of like a complex with the vasculature and with the kidney and the vasculature of the kidney as well. And the reason that I think about it like that is because there's really important effects of some of the hormones that the adrenal makes on blood pressure and vasculature in general, as well as on how the kidney is performing, and it has influences on the nephron directly. The other thing to keep in mind is that the adrenal gland essentially is a specialized sympathetic nerve. So you have the preganglionic sympathetic nerves that actually directly innervate into the adrenal gland. And this adrenal gland is basically like a giant sympathetic nerve that acts as a reserve for your sympathetic nervous system. So what is produced in these adrenal glands? So you get signaling, CRH, ACTH, adrenal gland is stimulated. And really there's two big tissue types that you can categorize the adrenal gland into. So the first is the the cortex. So the cortex creates three different types of hormones. And all of these hormones are related because they're all steroids. So steroids are hormones that are basically derived from cholesterol. And those different hormones are very similar in terms of their actual molecular structure. So what you actually have is signaling from ACTH to help drive some of these enzymatic processes that are happening in the adrenal cortex that leads to development of a few different unique steroids that have varying and unique physiological effects. So the important thing to keep in mind is that the pathway of steroid genesis within the adrenal cortex actually starts with androgens, and you need some really important enzymes to help facilitate and augment these different steroid molecules to create cortisol and to create aldosterone. So one example of a critically important enzyme is the 21-alpha hydroxylase, which you guys should remember, and we'll get into why that specific enzyme is so important in a little bit. So what you have here is ACTH signaling to the adrenal gland to start making different steroids. It starts with androgens that are made first, and then it's modified through enzymes to create cortisol and aldosterone. Now, the other tissue type in the adrenal gland is the adrenal medulla. And really what that is signaled by is through that sympathetic nervous system. So stress and increased sympathetic tone will lead to direct release of the catecholamines, which are epinephrine and norepinephrine. So again, that adrenal medulla is really a reserve for extra catecholamines to help respond when you have extraordinary sympathetic tone, which is needed for something in your environment to react to. So just like every other pituitary axis, there's negative feedback that helps control the levels of these hormones. So the primary compound or molecule that's doing the negative feedback is cortisol here. So as you can see, cortisol negatively feeds back and inhibits CRH and ACTH centrally. And that allows you to have physiologic levels of cortisol. Okay, so it's the Goldilocks principle, not too much, not too little. Now, the other thing that cortisol does that you have to keep in mind is the effects that it has to potentiate other physiological effects or other hormonal effects. So not only does it have negative feedback to stop ACTH stimulation of the adrenal gland, it also has potentiation effect or sort of like positive feedback, you can think of it as. And the main thing that it has positive feedback on is the blood vessels here, and it allows and potentiates, facilitates vasoconstriction to maintain your blood pressure. And it also facilitates aldosterone signaling in the kidney. So it facilitates that distal nephron salt reabsorption and kicking out the potassium and the hydrogen ion on the distal nephron. In fact, this is such a strong effect that high levels, so supraphysiological levels of cortisol in and of itself can actually mimic like a hyperaldosterone syndrome, and you can get that effect in the distal nephron. So you see aldosterone here and you're thinking, okay, so if you're making aldosterone, why isn't this one involved in the negative feedback of the HPA axis? And the reason is because aldosterone has a couple other really important features that are critically important to be controlled through other mechanisms. And that's mainly through the potassium concentration in the serum and also the RAS system. So don't forget that aldosterone is a hormone that's also released when renin is released, signaling the RAS system, and also reacting to hyperkalemia, because that is also an important tight physiological parameter that we have to control. So that's the reason that aldosterone doesn't have a strong effect on the HPA axis itself, because it needs to independently function. But because of the structure of aldosterone and it being so similar to these steroids, it makes sense for it to be made in that adrenal cortex where other steroids are synthesized. So the other few extra things that are helpful to know clinically about this pathway, so this is just like a little bit of extra information, is that not only is the negative feedback from cortisol also decreasing the cortical-releasing hormone as well as ACTH, it also inhibits ADH. Okay, so you inhibit ADH, which means you have less ADH signaling in the distal nephron, less aquaporons, less water reabsorption, and you get more urine produced that is dilute. Okay. The other thing to keep in mind is that ACTH actually is produced and synthesized as multiple different signaling hormones that are proteins, and they get cleaved into different hormones that have different effects. And one of the things is that when CRH tells the pituitary to make ACTH, you actually have a hormone that's made that's called POMC. And one of those derivatives of POMC is ACTH, as well as melanocyte stimulating hormone. Melanocyte stimulating hormone acts on the skin to stimulate melanocytes and cause pigmentation of the skin. And that'll be important for certain pathophysiological states in the HPA axis. So
Paul,
why does this all happen?
Just to correct that, just a slight correction, is that the POMC is actually a gene, and then it encodes ACTH and MSH rather than being a big hormone. So it's where you encode both ACTH and MSH. So if you rev up the expression of POMC because you need more ACTH, you automatically also rev up MSH.
Perfect. Thank you for that clarification. So we have Dr. Basuni in the background here today as well, who's going to give her expert tips and pearls as we go through as well. So thank you for including that, Dr. Basuni. So when we talk about, like, why does this all happen? We all sort of know the reasons why epinephrine and norepinephrine may need to be released. So remember the fight or flight response in general. But what is it about these steroids that need to be released to react to stress? And so remember that steroids are usually lipid soluble, which means they can go through cell membranes and get into cells and even into the nucleus of cells and directly affect the transcription and the translation of genes among a broad variety of different genes. So they have like very broad effects, and essentially cortisol receptors, I believe, are ubiquitous on cells within the human body. So they have a lot of effects. So what is this stress and why does it happen? So when you have to think about, a stress response, really, this is comes in a variety of different severities or a continuum of different intensities. So even every morning is to a certain degree a stress response that's required to wake you up from sleep, raise your blood pressure as you stand up from laying down, making you more alert and giving you that energy to start your day. So that's why we see naturally within the HPA axis a diurnal variation where you have increased signaling in the morning to help you wake up and respond to that stress of waking up. I definitely find waking up stressful some mornings. And then also decreasing throughout the day to have a lower level in the evening to allow you to sleep. And so that diurnal variation is classic and a typical feature of this axis. Now, remember, the goal is to respond to this stress appropriately and to give you the tools to stay alive. So back in the day, that may be, things like responding to a predator in the environment, whereas today it may be more so responding to the stress of a test and motivating you to study and stay up all night to study for the test. Both are examples. And so these emotional and physiological stresses will increase the HPA axis and appropriately cause you to have more of these things available to your body to utilize. So really the physiological effects of these different things we can go through, but in the end, what they want to do is they want to increase blood flow to give you blood flow to your brain and to your muscles to react and to think properly. And it does that through vasoconstriction, as well as holding on to extra fluid in the distal nephron by reabsorbing sodium. And then it also kicks out some of these toxic things that we would produce potentially by reacting to a stressful situation. So that's kicking out extra potassium and hydrogen ions. Don't forget that cortisol is also a counter-regulatory hormone, if you remember from the teachings around diabetes. And so it'll also increase your blood glucose and facilitate basically catabolic metabolism to give you more energy available to the body. And then the androgens allow you to, again, increase your muscle mass and be more aggressive and respond potentially in a more advantageous way to some of these stressful stimuli. Okay, so let's get into the pathophysiological states. So on the side here, just to remind you, I have the pathway that we just went through with all the important clinical properties of it. So don't forget that the patient is the bioassay. So you have to think about this from the perspective of how would a patient present to you? What signs and symptoms would they have? What common laboratory tests do we do on patients that might show up and be indicative of a problem in the HPA axis? So there's really two presentations that you have to keep in mind that are most important that you can't miss. And that's because both of these presentations have associated mortality with them. So let's talk about this first one, which would be hypoadrenal. And that would be specifically in the adrenal hormone of cortisol or the glucocorticoids. And what happens is when you have a lack of this cortisol, you have not only a lack of negative feedback back to the hypothalamus pituitary, but you also aren't allowing proper potentiation of these hormones like epinephrine, norepinephrine, and aldosterone to vasoconstrict to hold on to the salt and water to allow your blood pressure to be maintained while you're responding to that stressful stimuli. So when people don't have that cortisol, they're not able to respond appropriately in terms of their blood vessels responding to something like an infection. And so what they have is shock. So shock means that you have poor organ perfusion, which is usually manifested in low blood pressure, right? So that's how we can like very easily clinically identify that. So shock meaning low blood pressure. They also might be tachycardic. The classic shock type in someone who's hypoadrenal or has adrenal insufficiency, in other words, is to have a distributive type of shock. Okay, so that's the extreme end of the spectrum, and we'll talk about how you might recognize that quickly clinically and how you would treat that clinically. Now, there's a spectrum of how severe someone might be deficient in their adrenal hormones, and specifically with cortisol. So people can also have other symptoms. So they'll have fatigue as well, right? Remember, you're responding to the stress. So if you can't have that normal morning stress response, then you're going to feel pretty fatigued and have trouble responding to that. Now, not only do you have lack of feedback on CRH and ACTH, but you also have lack of feedback on antidiuretic hormone, which means that you'll have extra release of antidiuretic hormone, which means you'll reabsorb more water through aquaporins in the distal nephron, and you'll be hyponatremic. So that can be a clue on your labs. Again, you have lack of a counter-regulatory hormone that can help bump up your blood glucose, so you can have hypoglycemia. And some other specific symptoms that you can see is abdo pain or arthralgias, pain in joints, and nausea and vomiting. So anyone who's pretty sick, looks shocky, is complaining of abdo pain and nausea and vomiting, definitely you're going to want to be suspicious of adrenal insufficiency. The other thing that happens, which pertains to this melanocyte stimulating hormone, is hyperpigmentation. And remember that this sign is not like a nice tan. You know, this is basically a non-uniform pigmentation of the tissues. And there's a couple spots that you can look specifically to try and see this. So like the gums would be sort of a classic finding, the palms of the hands, and you would see sort of abnormal pigmentation. It's not like a nice uniform tan from, or what you would expect for someone who does have that. Now, the other one that's really important to remember is the catecholamines. So of course, the catecholamines in your sympathetic nervous system is very important to stay alive. But if you have too much of it and you have exogenous or supraphysiological levels of these catecholamines, you can actually have sudden death from those, so like sudden cardiac death. And again, these usually present with a classic triad of headaches, palpitations, and diaphoresis. So they're not, you know, the easiest things to, they're not the most specific symptoms, but if you see that, and especially if these are happening episodically and you're seeing associated hypertension, then you want to consider the diagnosis of increased catecholamines, most commonly caused by a pheochromocytoma, which we'll get into in a little bit here. So what are some of the other effects that we can see in the abnormal levels of these adrenal hormones? So something that we can see is when we have excess of androgens. So in general, whenever you hear virilization, which basically means your phenotype looks more masculine, you want to consider, you know, like what is the appropriate amount of virilization or masculinization that someone should have. And when they have over masculinization, we call that virilization. And it depends on the life stage in terms of how this would manifest. So a really important one is in utero. So if you have excess androgens that are happening in utero, then you will have a baby, if it's female, that's born with ambiguous genitalia. You can also pick this up on males, but it's obviously a little bit harder. That's because they basically would be overdeveloped for their life stage. So they would have an enlarged penis, enlarged genitals in general. The other thing is then as you advance in the life stage, so as someone goes through adolescence, then you can see things like precocious puberty, you can see worsening acne, you can see hirsutism, which is an abnormally increased amount of hair growth. And then even later on in life, in more subtle, less severe elevations in androgen excess, you can see things like menstrual irregularity, erectile dysfunction, and infertility for both males and females. I won't spend too much time on excess cortisol because we have a slide coming up here on it, but don't forget This is a very important classic syndromic presentation. So it's called cushingoid. And a cushingoid presentation has, very classic findings that we'll go through in the next slide. And then just to kind of flesh this out, finally, aldosterone. So again, with aldosterone, you can see abnormalities specific to aldosterone either being deficient. So the most common thing that you'll see on history is salt craving. So specifically, people craving salt, and you hear stories about people like waking up in the middle of the night to chug pickle juice. Like it's a true, obvious, overt craving, which is pretty interesting. You can also get obviously hyperkalemia and acidosis because you're not kicking out the extra potassium and hydrogen ions in the distal nephron. Now, the opposite here, the excess, so hyperadrenal, which means excess of the adrenal hormones, the unifying factor here is hypertension. So you want to review and think back to your, first of all, your initial workup when you diagnose any hypertension, but also when you're particularly suspicious or working up secondary hypertension causes. So excess in the catecholamines, excess in cortisol, and excess in aldosterone can all cause hypertension. And remember, when someone is sick and responding to stress, they tend to lower their blood pressure. And so we want to counteract that by having a normal physiological response of raising the blood pressure up. But when we're well and we have extra of these hormones, that's when we start getting hypertension that we can measure with blood pressure. The only other important thing to kind of remember is that it's very difficult to tease out some of these things. Potentially they could be asymptomatic. So that's why laboratory investigations are also really important. So let's go through the different causes of being adrenal insufficient or having excess adrenal hormones. So again, just like with other pituitary axes, the most common ones are primary problems of the adrenal, and we'll get into secondary ones in a second here as well. But it's a short list. So really these ones that are important to know in terms of adrenal insufficiency is the autoimmune cause, which is called Addison's disease, as well as congenital adrenal hyperplasia. And the most common cause of that, more than 90% of cases, I believe, is a deficiency in that 21 alpha hydroxylase. Okay. There's also a couple other ones that are highlighted in your lecture notes that are good to keep in mind because they can definitely see these out in the community. The third one here is adrenal leukodystrophy, which is, again, adrenal insufficiency, which is genetic cause. It's X-linked, so X recessive, which means, if you remember from your genetics, much more common in males. So if you're seeing a male who's adrenal insufficient, they're young, could be a congenital cause, you want to think about this adrenal leukodystrophy. It is quite rare, but you want to keep it in mind. And then the developing world, infiltration of the adrenals by tuberculosis is also a common cause that you would want to keep in mind if you're working in that setting. Now, in terms of hyperadrenal, really the main things is different adenomas and carcinomas that are causing excess secretion and causing uncontrolled autonomous secretion of the adrenal hormones. So you can just go through them all. Hyperaldosterone, which is called Conn syndrome. Hypercortisolism, which would be a adrenal adenoma that's producing extra cortisol or glucocorticoid. And then again, that big one, the pheochromocytoma, which is really the most dangerous one for someone who looks well in front of you. So you always want to be wary of, could this be a pheochromocytoma? You want to ask about the specific symptoms. When you're thinking about the symptoms of a pheochromocytoma, think about someone having a panic attack, right? They're diaphoretic, they're tachypnic, they're tachycardic, they're sweaty, right? But because when you're having a panic attack, essentially what's happening is you're having an increased sensitivity and physiological response to catecholamine release, okay? The other thing to keep in mind with adrenal diseases, there is a couple common secondary causes. So in general, secondary causes, which include central causes, so problem with the pituitary or hypothalamus, are rare. But because we use glucocorticoids for treatment of many different diseases, autoimmune diseases primarily, you want to keep in mind, what are we doing to this patient that could be affecting their HPA axis, either giving them superphysiological amounts of a corticosteroid, or when we take it away, inhibiting the HPA axis and making them adrenal insufficient. The other one that is a non-iatrogenic cause that you want to keep in mind is a pituitary ACTH adenoma. So in general, adenomas in the pituitary that are causing abnormalities in the hormones on pituitary axis is rare, but there's three big ones that you want to keep in mind. So the most common pituitary adenoma is a prolactinoma. So that's one that's releasing prolactin. The other one would be a pituitary adenoma that's releasing growth hormone. And then lastly would be one that's releasing ACTH. Okay, so this is very common. So when someone is cushingoid, which means they present with the patient bioassay, so signs and symptoms of high cortisol or high glucocorticoids, actually the most common cause of that would be a pituitary ACTH adenoma, about 70% of those people. So that is specifically called Cushing's disease. Okay. Now, it's interesting to work through this pathway, especially with congenital adrenal hyperplasia. So we'll just do that quickly here, okay? So again, you have CRH release, ACTH release, signaling the adrenal cortex to produce steroid hormones. So in congenital adrenal hyperplasia, that acts normally, and you have the adrenal cortex responding to produce androgens, but they get stuck after this step. And because they get stuck at this step, they start building up androgens. Now, the issue here is that androgens do not have negative feedback on ACTH, only cortisol does. So now you have excess androgens, which lead to virilization. You have cortisol that's not being produced because you don't have the enzyme that is modifying androgens to create cortisol. And you don't have the negative feedback from that cortisol. Okay, so no negative feedback means more ACTH, more androgens. And then when you get more of the POMC gene being stimulated and transcripted, you'll also get more melanocyte stimulating hormones. You can see some of that hyperpigmentation in that state as well. So it's really interesting that you get an excess of some of the adrenal hormones, but a lack of other ones. And that is because of the physiology driving certain elevations in certain signaling hormones along this pathway. What we're going to move on to now is talking about Cushingoid syndrome specifically. Okay, so Cushingoid syndrome is something that you should be able to recognize, but it can be difficult to recognize. So I noticed in one of your lecture slides, they did mention something along the lines of like pseudo-Cushingoid. And that's not like a real medical term and not something that we use with patients or anything, but it just isn't interesting. It brings up the idea or the principle behind that. There's many different manifestations, so signs and symptoms of having excess glucocorticoid in the body that you can pick up on. And those aren't necessarily specific to having excess cortisol. So you always want to think about, so for example, when you're diagnosing someone with diabetes, you got to do that physical exam. And if you see things like purple stria or the moon facies or the fat pad, the dorsal fat pad, you got to think to yourself, should I be investigating this person for high cortisol, for Cushingoid syndrome? So Cushingoid syndrome is the clinical manifestations that is unique and different from Cushing's disease. Cushing's disease is one of the etiologies, as we just went through, which is the pituitary adenoma that's producing ACTH that can cause Cushingoid. But Cushingoid syndrome has a differential along with it, and we'll kind of go into those in more detail in the next slide. So remember, there's many different broad effects. You don't have to memorize all of these, but just think about the really big ones that you might be able to pick up on that are a little bit more specific. So for me, definitely, you know, like that dorsal fat pad, the moon facies, the purple stria, having extra bruising, having muscle weakness, having extra central adiposity. All of these things seen together and seeing more of them together would increase your suspicion that someone has Cushingoid syndrome. So the first thing that you want to do is you want to confirm that they have increased cortisol. That's the first step. And what we really do is we take advantage of that diurnal variation that we talked about earlier to test if the cortisol levels are appropriate. So probably the one that I use most commonly in the outpatient setting would be a 24-hour urine-free cortisol. So again, it's a little bit intensive in terms of collecting urine for 24 hours, but these can give you accurate results. There's a couple other options, and these ones are more often I see used sort of in the inpatient setting, maybe because it's just a little bit quicker in terms of how quickly you get the results back. But you can also do a 12 a.m. salivary cortisol, okay? So what would you expect to see in these? Let's go through two as well. So 24-hour and free cortisol, you would see increased cortisol overall above the upper limit of normal, okay? And that'll be dependent on the lab assay, but it'll be reported with it. And then number two, what you'll see is you'll see an elevation above what you'd expect in terms of the 12 a.m. salivary cortisol. Because remember, the normal pattern is to be high in the morning and low at night. So this is really your physiological low. So that's when you're more sensitive and more able to pick up increased cortisol. Because if you have endogenous created cortisol that's high, basically you lose that variation and you just have high levels throughout the day that stay high. The other thing that you can try to do, just like with other endocrinopathies, is you can try and suppress something and see if it gets suppressed appropriately. So again, remember, cortisol is the main negative feedback in the system. So if you give a glucocorticoid like dexamethasone at a physiological or maybe mildly super physiological dose, like 1 milligram at night, then that should inhibit centrally CRH and ACTH release, and you should see low levels of cortisol in the morning. We use dexamethasone because when we measure cortisol, the dexamethasone doesn't get mixed up in that assay. It's different enough looking. So what you do is you give them dexamethasone at night, and then the ACTH should be turned off, the adrenal glands should be turned off, and you should have no endogenous cortisol or low levels of it, okay? So if you inappropriately have normal or elevated cortisol levels, even after trying to suppress it with the dexamethasone the night before, then what you're left with is confirmation that you have a Cushingoid syndrome and endogenous high levels of cortisol. So the next step then is to find out the etiology of that. So the two most common causes that you can differentiate would be to do a serum ACTH level. So if you have high ACTH, that's also called ACTH dependent Cushingoid syndrome, then you'd be very suspicious of something producing ACTH in the body. On the last slide, we talked about the couple different reasons that can happen, but the most common would be actually a pituitary adenoma that's producing ACTH, which is Cushing's disease. The other thing that you would want to think about would be if ACTH was low, and that would be an ACTH independent Cushingoid syndrome. And the most common cause of that would be an adrenal adenoma. Okay. Now, based on where you think the issue is, then you have to go and confirm that with imaging to see if you can find that. Okay, because that can dictate your management, which we'll talk about in a little bit as well. Okay, now that we're on the subject of just testing cortisol levels in general, you also want to think about how do you confirm if cortisol is low. So if someone is adrenal insufficient, okay? So first of all, you don't want to wait for a lab test to confirm that someone has low cortisol if it's an emergent adrenal crisis, right? So if they're in shock, and we'll talk about what that can look like in a little bit. But if someone is suspicious for being low in cortisol, so remember those other symptoms we talked about, like abdo pain, nausea, vomiting, fatigue, they're hyponatremic, okay? Then you want to do an 8 a.m. serum cortisol, okay? Because that's when you should be at your physiological peak. Now, if it's below 100, so if it's in double digits, that is very consistent with adrenal insufficiency, and you can probably treat them as adrenal insufficient. If it's between 100 and 350, it's hard to say. Some of those people in that range are adrenal insufficient, some of them aren't. And then if it's above 350 at that 8 a.m. serum cortisol, then you would have essentially ruled out it's highly unlikely that someone is adrenally insufficient. Now, if you're unsure, you can repeat this, but the gold standard test is doing an insulin tolerance test. So why does that happen? So let's think about it through the pathway. So you give someone insulin, you lower their blood glucose. Okay, when someone's blood glucose is lowered, what's the body going to do? It's going to shut off insulin and it's going to start production of counter-regulatory hormones. Remember what the big counter-regulatory hormones are: cortisol, growth hormone, and catecholamines. So you're going to see a rise in that. So you're trying to stimulate basically cortisol release from the adrenal glands. And if it's unable to do that, if it's unable to respond to that stimulus, you've confirmed that they're adrenally insufficient. So let's go through some of the other adrenal diseases in general and we can talk about their specific features that you would want to consider and think about and what could potentially help you differentiate them. So the first one that we're going to talk about is Addison's disease. Okay, this will definitely come up on your guys' tests, and you guys need to know about this one. So really the big thing on Addison's disease, what you want to think about, this is autoimmune attack of the adrenal glands. So you have primary adrenal insufficiency. What that means is the adrenal gland cannot create androgens, it cannot create cortisol, it cannot create aldosterone. So it'll be low in all of those things. Because there's no negative feedback, you also have increased levels of ACTH and increased production of the melanocyte stimulating hormone. So because you have extra MSH, you're going to get the hyperpigmentation, which again is this, diffuse, non-uniform hyperpigmentation of certain mucous membranes in the skin. And then you're going to have those salt cravings because of the aldosterone. Those are quite specific, and you should definitely be thinking about Addison's disease and adrenal insufficiency in general when you see those. Now, you're also low in cortisol, so you could do those confirmatory tests, the 8 a.m. cortisol, or if you needed, the insulin tolerance test. And then you're also going to see them being hyponatremic, again, because ADH is not being inhibited, which means more ADH, more aquaporins in the distal nephron, more reabsorption, hyponatremia, okay? You're also going to be hyperkalemic because aldosterone is not acting. You can test for anti-adrenal antibodies, and they're actually pretty good tests. So if you're unsure or it's unclear, you could add those to the workup as well. And then you want to think about someone's history and someone's past other medical comorbidities as well. So either a personal or family history of these autoimmune diseases. So the endocrinopathy autoimmune diseases kind of go together. So Hashimoto's, autoimmune thyroid disease, okay? Diabetes, right? Pancreatic, beta cell, autoimmune disease, vitiligo, skin autoimmune disease, and then pernicious anemia. Those are really the really commonly associated autoimmune diseases with Addison's. And then lastly, what you want to think about is this adrenal crisis? So you won't have enough time when someone's in a true adrenal crisis to do all of these tests necessarily and take this, history of, does this person have hyperpigmentation? Have they been craving salt? So you want to consider this whenever someone has shock and they're not responding to IV fluids and vasopressors. So remember, cortisol is required to facilitate that squeeze on the blood vessels with epinephrine and norepinephrine. So if you're seeing that, you want to stress dose them with corticosteroids and see if their shock improves from that, okay? And remember, the most classic shock will be that distributive shock. So remember what distributive shock is. It means the heart's working well, so you have good cardiac output, but it's distributing that output to everywhere in the body inappropriately. So you have warm peripheries, you have bounding pulses. Yeah, those are the big findings with distributive shock. So that's Addison's disease, okay? And then you have to replace all of these hormones with Addison's disease, but we'll get into that in the next slide in a little bit. Congenital adrenal hyperplasia, we've talked about a bit already. So again, you have excess buildup of androgens and no negative feedback. So it's just continually being stimulated. So what do you end up seeing? So first of all, why is it called congenital adrenal hyperplasia? Well, this is a genetic inherited disease. So you see it very young. That's why we call it congenital. And then adrenal hyperplasia. So remember, just like with other end organs, if you have a bunch of signaling hormone that's telling this gland continuously to make more, it's going to hypertrophy to try and respond to that stimulus better. So with this, when you have no cortisol, no negative feedback, you have increased levels of ACTH and you get continuous stimulation, and these kids are born, and you can see on imaging really big adrenal glands, okay? Now, specifically what you can measure in terms of androgens is the 17-OH progesterone, which again, you can stimulate even further with an ACTH stim test. So you don't have to do that, but it can be helpful in the diagnosis. And you can also see DAGAS. These are two different types of androgens that are made specifically in the adrenal gland and can be helpful in diagnosing congenital adrenal hyperplasia. And then of course, you'll see that adrenal insufficiency from a cortisol and an aldosterone standpoint. Okay, so you can confirm low cortisol levels with your 8 a.m. cortisol or with your insulin tolerance test. Adrenal leukodystrophy, just to touch on it quickly, often if you see a young male with developmental delay or neurological symptoms, then you definitely want to consider this. Of course, this is a adrenally insufficient presentation, so you would see a presentation consistent with that. And really the test to do is this very long chain fatty acid, and these would be elevated, okay? And that would be consistent with this disease. Now, iatrogenic, so what we do to people, the main things to keep in mind is like anytime we give someone corticosteroids that's above physiologic, so we're not just replacing because they're adrenally insufficient, we could cause a Cushingoid type syndrome response. And then adrenal insufficiency, the really important thing to keep in mind is that anyone that's consistently or was on a reasonable amount of corticosteroids for any regular amount of time can be adrenally insufficient for 6 to 12 months. And basically that just works again through inhibiting centrally the hypothalamus and the pituitary to inhibit CRH and ACTH. And it can take up to 6 to 12 months for the CRH and ACTH to fully recover, okay? That doesn't mean you're completely adrenally insufficient for 6 to 12 months, of course, but let's say you had to respond to something like sepsis, or ARDS, some of these critical illnesses, then you potentially would be relatively adrenal insufficient even that far out. Cushing's disease, so again, this is ACTH dependent, so you'll see the high cortisol confirmed from those 3 tests and the high ACTH, and then your next step is doing that MR pituitary. Okay, so you want to do an MRI of the pituitary, and if you see a nodule that's consistent with an adenoma there that's producing ACTH, you have your diagnosis. Now, there's other causes of these that you can keep in mind, but it's a little bit outside the scope. Really, what you want to keep in, really what you want to focus on is that most often this is due to a pituitary adenoma. Don't forget that you can have any pituitary tumor, like a craniopharyngioma, that can cause you to lose function with your pituitary hormones. So the mass effect happens in an ordered way. So it's kind of interesting to know this. So first you would lose ADH and growth hormone. Next, depending on the size and infiltration, you would lose FSH and LH. And then lastly, you can use TSH and ACTH. So it'd have to be quite a large tumor for you to start noticing adrenal insufficiency. And remember that prolactin is the unique pituitary hormone where you actually have inhibition from the hypothalamus instead of stimulation. So actually, if you have loss of inhibition, you have increased prolactin. And then just to go back kind of on a broader view in terms of the anatomy around the pituitary, don't forget about the specific mass effects that can happen around the pituitary tumors. So right above the pituitary is the optic chiasm, right? So if this thing is growing up towards there and putting pressure on it, that's where you get the bitemporal hemianopsia. Right beside the pituitary, okay, in those sinuses, you have your extraocular nerves, or sorry, your nerves that control your extraocular eye movement. And so you can get diplopia and variable effect on each eye and the muscles that control those eyes. So you get problems in your vision, you see double, okay? The other things that you can get is headache, and that's just from the general mass effect. And then again, right below the pituitary is your sinuses. So you have your sphenoid sinus, right? Some thin connective tissue, and then your open sinuses. So if this tumor is growing straight down, then what actually you might notice is that people have postnasal drip or rhinorrhea, which is actually their cerebrospinal fluid dripping down through the soft tissues there that have been disrupted by this tumor. Okay, the last thing to touch on for this slide is the different hypersecretory adrenal adenomas, okay? So just like other endocrine glands, you have to keep in mind that nodules are very common, okay? So like 5 to 10% of all adults will have an adrenal adenoma, and the large majority of those are benign and not secreting anything, or not secreting anything to a degree where we would pick it up on our tests or we would pick it up on the patient bioassay. So you have to keep that in mind. So that means that we often find these incidentally. So we call them incidental adenomas on the adrenal glands. And again, 85% of them are benign, non-functioning. We don't have to worry about them, okay? Now, the main thing is when you find a nodule, you have to think about, could it be secreting something? Because there still is 15% of them that are either not benign or they're secreting something. So you have to think about, do they have symptoms? Okay, so you want to go back to that slide of the signs and symptoms of the excess of these, okay? So you want to ask if they have excess catecholamine release. So that again would be hypertension, episodic headaches, palpitations, diaphoresis, tremor, okay? Even if they don't have those symptoms, you're going to test them for a pheochromocytoma, because the one thing that you can't miss, which could be asymptomatic, is a pheochromocytoma, and you can't miss it because people can die from it. So no matter what, an insulinoma requires one thing. It requires a history and a physical, of course, but in terms of investigations, you have to do a 24-hour metanephrine, okay? Increased 24-hour metanephrine is consistent with a pheochromocytoma. You'll want to ask them about hyperandrogen symptoms, okay? So ask them about acne, ask them about fertility, ask them about libido, ask them about erectile issues, ask them about menstruation, ask them about hirsutism, etc. You want to ask them if they're cushingoid and assess them to see if they're cushingoid. And then you also want to potentially assess if they have hyperaldosteronism, okay? Not something that you have to test for every time, but if they have either signs or symptoms of it, or on investigations you've picked up something like, let's say, hypokalemia, then you would definitely want to test them. And the test to do for that would be an aldo-renin ratio. The main thing to keep in mind is that you do not want to biopsy these things. No matter how concerning they may look, biopsy is not the answer. The issues with biopsy is that if it's a malignant carcinoma on the adrenals, then you can see the tract that the needle goes through. The other thing is that if it's a pheochromocytoma and you cause a large sudden release of catecholamines, you can actually cause death from that. So you don't want to biopsy these things. Now on imaging, we talked about nodules, we talked about if they're secreting or non-secreting. You can also see a couple other patterns, okay? You can see multinodular bilaterally enlarged glands, which again, you would approach the same way as a benign nodule, okay? But the other thing that you want to be concerned about is cancers that can be in the adrenals. So it can either be a primary adrenal cancer, which again is quite rare, or it can be a metastatic cancer from like lung, breast, colon cancer. There's many different types, but you want to keep those in mind. So especially if they have a history of cancer, that'd be quite suspicious of metastases. If it's irregular, if it's larger than 4 centimeters, those are really the big cutoffs that make us more suspicious of it being a malignant lesion on the adrenals, and we'd want to refer them to a surgeon and refer them for further imaging potentially. Okay. So last thing here is just to talk about management quickly. So when it comes to management, first we'll talk about adrenal insufficiency, which again, really the big one, because the key hormone in this is being low on cortisol or glucocorticoids. Of course, sort of the prototypical one that you can think about is Addison's disease, because they have autoimmune attack of the adrenals, they'll lose function and they'll be deficient in all of the cortical adrenal hormones. So low in glucocorticoids, low in aldosterone, low in androgens, okay? So really what you want to do is you want to make sure that these people understand the severity of their disease, right? This is something that can kill them if they don't have an adequate intervention when they have a physiological stress, okay, when they become ill. So again, don't forget your adrenal crisis. So shock that's distributive, that's not responding to IV fluids and vasopressors as normally. They still need the IV fluids because they're sick. So they usually need, quite a bit of IV fluids, but you need to stress dose them with hydrocortisone. So the most common dosing used is 100 milligrams IV. So always consider that if you think that this could be adrenal crisis based on the presentation or comorbidities of the patient. And then you treat the underlying illness as well. Now, when someone is well, what we do is we replace these hormones in physiological levels, okay? So glucocorticoids you need, they're the most important hormone there, arguably. So hydrocortisone is interesting. So remember when we talked about when the steroids are made, there's actually just these subtle modifications that are made on side chains. So some glucocorticoids not only have a glucocorticoid effect, but they also have a mineralocorticoid effect. So they have the effect of cortisol plus, to a lesser degree, the effect of aldosterone. And hydrocortisone is one of those medications. So often people, even who have Addison's disease, may get away with just using hydrocortisone, okay? So normal physiological levels is 20 to 30 milligrams. The equivalent of that in prednisone is 5 to 7 milligrams. So I really just want you to highlight that when we're treating someone for an autoimmune disease, we're giving them 60 milligrams a day, 40 milligrams a day for long-term of prednisone. So this is very much supraphysiologic, and you can definitely induce cushingoid symptoms, okay? Now, mineralocorticoids, sometimes you do have to give those, especially in Addison's disease, because they may have quite a severe deficiency in aldosterone, not being making any endogenously. And we use fludrocortisone, which again is just another steroid that has more of a mineralocorticoid effect as opposed to very, very minimal glucocorticoid effect. Okay. So you want to make these people aware that when they're well, they need to take their medications regularly. And then when they're unwell, they need to, first of all, make other people aware of the condition that they have. So a medical alert bracelet, as well as manage themselves appropriately. So if they have mild or moderate illness, say like a typical cold or flu, they'll need to take 2 to 3 times their typical PO dose, okay? Now the trouble is if they're not holding down that PO dose. So if they're unsure, if they have any nausea or vomiting at all, we highly recommend that these patients go to the emergency department for IV corticosteroids. Or you can also give them an IM kit to inject it parenterally, and they may be able to stay home or at least buy themselves some time to get into the emergency department. In critical illness, there's lots of debate about whether or not to use corticosteroids. Really, in general, if someone is known adrenal insufficiency or highly suspicious for it, then you can consider giving them a large corticosteroid dose IV. Okay, so there's certain indications around this, and I won't get into the nitty-gritty details, but people who are very, very sick sometimes also need steroids, especially if they're adrenal insufficient, they need those steroids. Now, when it comes to mineralocorticoids, you don't really need to stress dose it. You only stress dose it if someone is sweating significantly. For example, they're out to run a marathon, and then you maybe double their PO dose of fludrocortisone that they might be taking. Okay, moving on to the hyperadrenal states. So again, as with everything, you want to educate the patient on what this is, why it is that we need to treat it, why it's important for them, and then you want to treat it. Now, typically you want to think about pharmacotherapy first, but with these conditions, so hyperadrenal symptoms or excess adrenal hormones, really the mainstay of therapy is actually surgical intervention, right? So this is first line. So you want to consider them for surgical intervention first. So if you made a diagnosis of Cushing's disease, remember how I said the pituitary is very close to the sinuses, to the sphenoid sinus, they can actually do a transsphenoidal resection. And then sometimes they do need to use radiation as well to consolidate the treatment for Cushing's disease and get rid of that pituitary adenoma that's producing ACTH. Now, for other adrenal adenomas that are producing any of these hormones, so extra catecholamines, extra androgens, extra aldosterone, extra cortisol, you would consider them for adrenalectomy first, but it has to be only one side, okay? If it's both sides, it's not really potentially worth it to go after and make them adrenally insufficient altogether because you've taken both their adrenal glands. The other thing to consider is whether or not they're a good surgical candidate in general. So if someone has a lot of comorbidities and they're older and they're at high risk of going under the knife for general anesthesia, then you may want to consider other options. So that's other options is the pharmacotherapy. So I have them listed here, and I wouldn't necessarily remember the specific names here. A couple important principles that with a pheochromocytoma, of course, this would be surgically resected if possible, but if unable to, you want to help protect them from that mortality associated with this. So first, you always give them an alpha blocker, and there's some examples there. And then sometimes you can also give them a beta blocker as well if needed, but you always give them that alpha blocker first. And then with these other ones, there's a couple specific inhibitory molecules and drugs that can inhibit them as well. Now, just in terms of follow-up, you always want to consider if you've actually overdone it here and made someone adrenal insufficient in some way, and that's quite common actually in the transsphenoid surgery for Cushing's disease, and so you may actually need to make sure that they're not adrenally insufficient after that. The other thing with pheochromocytomas is that a certain proportion of them are malignant and will recur, so you want to monitor them for recurrence. So the same way you would make the diagnosis before with a 24-hour urine metanephrine, you may want to do that at certain intervals after they've been treated. And then lastly, the biggest thing is the cushingoid complications. And I won't get into too much details here, but when either we do it or endogenously there's too much cortisol in someone's body, we always think of the ramifications of that can happen in the short and long term. The biggest worrisome one is the immunodeficiency. So often we'll put people on prophylactic antibiotics if they're on really high corticosteroid doses that we're giving them. But we want to think about, hey, if this person has fever or other signs of illness, they need to be very closely monitored, have a low threshold to present to things like the emergency department. And then also the long-term effects, like a big one being like the osteoporotic effects of having extra cortisol. Okay, and don't forget, do not biopsy adrenal adenomas. Okay, that is not part of the workup or the intervention for these, and it can be dangerous. So I think that that's everything that I want to go through today in terms of the adrenal axis, and hopefully some pearls about pituitary diseases in general as well. Again, if you have any questions at all, please feel free to pass them along to me.